podcast where we discuss in the paper entitled Preoperative Gabapentin for Minimally Invasive Hysterectomy, a randomized controlled trial. In this study, 129 women were randomized to either receive a preoperative regimen of acetaminophen, celecoxib, and gabapentin versus acetaminophen and celecoxib alone. They found that a single dose of preoperative gabapentin for women undergoing a benign, minimally invasive hysterectomy did not reduce total opioid use following surgery. We are lucky to have with us today two of the authors, Dr. Terri Huynh and Dr. Gretchen Makai from the Christiana Care's Department of Obstetrics and Gynecology. Thank you both for being here. Just to start it off, let's get right into it. What was the motivation for performing this study?
Yeah, I would say jokingly, my motivation was my fellowship research. So it was mainly for graduation purposes and to get something done. But at the initial motivation was really, this was Gretchen's concept and her idea. This was in our institution, they had just recently instituted a new ERAS protocol, which included giving preoperative medications as a single dose, including gabapentin. And prior to this, we had never done this before. So we were curious to see what the true effects of these medications were in our patient population, specifically in minimally invasive surgery, where a lot of the benefits for ERAS were already ingrained in much of the minimally invasive benefits, such as early discharge and things like that. So we're curious to see, does gabapentin have a benefit or does it not for our patients?
So specifically, I became interested for a couple of reasons. Certainly all of us could get excited around doing better by our patients, improving perioperative care, and helping them feel even better. I think that's a huge motivator for most of us as minimally invasive surgeons, that we're really interested in making our women feel better faster so that they can get back to their regular life. That being said, when Terri entered her fellowship and this started, this ERAS protocol, I've been operating for years. I won't say how many, but many, and not had too many struggles, not had too many obstacles getting patients home the same day and feeling pretty good. So suddenly my patients went from not being allowed to have anything by mouth, anything, until the day of surgery, to taking 4 medications by mouth within an hour before surgery. The protocol that they initiated was Tylenol, acetaminophen, celecoxib, gabapentin, and oxycodone in select cases. And it just seemed to me like, wait a minute, we went from not having too much trouble in minimally invasive surgery, would love to make it better, to now 4 medications. So the question is really twofold. One is, are we helping our patients? Great, let's see how we're helping them. But what of all of this do we actually need? Because over-medicating patients is also not beneficial. So trying to tease out what was new, what was useful, and how we could do right by our patients.
That's a very interesting point. Now, was there a specific reason you looked at gabapentin? Were there potentially any adverse effects you were trying to avoid in that kind of multimodal pharmaceutical strategy that was being initiated with the ERAS protocol?
Yeah, with gabapentin specifically, there are definitely some side effects that we could be concerned about, such as some of the more common things include being tremulous or somnolent. We're worried that potentially that could have an effect in terms of same-day discharge, but it wasn't the motivating drive for this paper. We selected gabapentin in large part because for our patients, when they were given these medications, some of the medications were more familiar versus the other, and we knew that gabapentin was something that's relatively newer to most people. Maybe they've never had it before, so they were less comfortable with it, and similarly, they knew they could tolerate or not tolerate an NSAID versus acetaminophen. So we opted to make a cleaner study also by selectively choosing one medication rather than randomizing patients to no preoperative medications versus all 3, to really kind of tease out and figure out, is this selective medication beneficial, to help begin painting the picture of what are the right medications for our patients and whether they're helpful or not. So yes, the side effects are something that were a consideration, but probably not the motivating factor in this situation.
What is your institution's current ERAS protocol for your minimally invasive hysterectomies?
Yeah, so for the ERAS protocol at our institution, it wasn't specifically for just hysterectomy, but for all surgeries. So all surgeons across our specialties were instituting the same protocol that was designed by our anesthesiologist, who really took the lead in bringing this to our institution, which is really great. But ERAS in general is a multifaceted protocol, so it includes preoperative, intraoperative, and postoperative tenets that are supposed to be designed to help improve patient outcomes in terms of getting them back to bowel and just general functioning earlier, to help reduce narcotic use and also return them to bowel functioning, and home earlier, reducing hospital length of stays, things like that. It initially started with colorectal literature, I believe, and was expanded to other specialties. And so for our institution included, in addition to preoperative counseling, which is done kind of more on an individual basis across subspecialties, it also included allowing patients to have clear liquids up to 2 hours prior to coming in, as well as these preoperative medications, which includes acetaminophen, typically 975 milligrams, celecoxib, which was 400 milligrams, and then gabapentin, which they were at the time giving 300 milligrams at our institution. The anesthesiologists then have their own protocol in terms of intraoperative management to help reduce excess fluids, maintaining patient temperature, things like that. And then in terms of postoperative care, the goal was to have patients return to functioning as soon as possible. So minimizing how long they had a Foley in place, returning patients to eating a regular diet as soon as possible, things of that nature. For our hysterectomy patients, there's a couple things that we did from a postoperative standpoint, including we promoted same-day discharge by having a retrograde trial avoid protocol in place. So patients would then have this trial avoid and hopefully go home on the same day. We also gradually instituted, not at the time of the study, but gradually we instituted a hysterectomy class that all patients could go to get some basic counseling on hysterectomy and preoperative counseling. And honestly, I think that probably makes the biggest difference in terms of setting patient expectations about what to expect for their surgery, when they might go home, things like that. Because I think many patients may hear from their mom or their grandma who had a hysterectomy that they stayed in the hospital for 5 days, and now they're shocked that they're going home on the same day. So I think setting those expectations are really, really helpful. And they also get a book, or they can go online and get that same information that way. So those are the ways that our institution instituted the protocol from an anesthesia standpoint, and then we kind of hijacked it for our study.
Maybe we kind of look at table 3, where you look at postoperative narcotic use and pain scores of patients who did and did not receive gabapentin in the Egress protocol.
Sure, yeah. So our groups were randomized to receiving 600 milligrams of gabapentin, which at the time was a little bit more than our institution, plus acetaminophen and celecoxib, versus the control group, which has got acetaminophen and celecoxib. And our primary outcome was looking at narcotic use, at total narcotic use at 24 hours post-operative. But we did collect data on narcotic use throughout their time course, as well as up to 2 weeks post-operative, and looked at post-op pain scores as well, just to get a better understanding of the pain picture. This table shows what their use in terms of narcotics were, as well as what their pain scores were. And there were no differences that were significant between the 2 groups. So whether we see gabapentin or not, we found that they had no differences between their uses at any time point, and specifically at the 24-hour time point, which was our primary outcome. We didn't find any differences in terms of postoperative pain between the 2 groups, and this was at several different time points, including when they arrived to the PACU, at 24 hours, as well as kind of their average pain at 2 weeks postoperative, just for comparison purposes. So we didn't see any differences.
Let's quickly look at figure 2. Were there any specific differences in the adverse effects of those who did and did not receive gabapentin?
We didn't see any differences in terms of adverse events or symptoms, really kind of side effects or symptoms. We didn't have any actual adverse events, but in terms of common side effects like somnolence or nausea, vomiting, tremulousness, feeling like there's some difficulty walking with their gait, we found both categories, whether we see gabapentin or not, both subjects and groups actually had both symptoms, and there was no difference in terms of rates. So it suggests that perhaps it's not the gabapentin specifically, but some other elements of surgery that may cause some of those symptoms. So gabapentin itself did not affect those side effects.
So moving forward, is gabapentin going to be a part of your Egress protocol for your hysterectomies?
Well, for the institution, it still is. We'll put it that way. I'm a big believer in the scientific method, and that studies should be reproduced before we make major changes in terms of how you're practicing. I think this is a well-designed study since we're able to do a randomized trial, and it was appropriately powered. And so it definitely makes an argument that you may not need gabapentin for minimally invasive hysterectomy, as there may be other elements of the surgery method, other elements of the Egress protocol that was in place that can also help give you the same outcome. They may not need to use gabapentin, but there are some patients who I could see potentially having some benefit, particularly if they're having issues with chronic narcotic use. Maybe this is a mechanism that potentially could help. We didn't study that specifically, so we don't know. It could be another fellowship project if someone wants to take that on. But I currently use it as somewhat sparingly, but I let my fellow honestly choose what she wants to do. And if the anesthesiologist want it, I have no problems with them using it, since our safety profile seems consistent with all the data out there that a single dose gabapentin use is safe to use, and I won't give excessive pushback.
For me personally, there will never be a more applicable study, and knowing that the study was well powered, a randomized controlled trial, and even attempting at blinding patients. Certainly their providers were blinded, but looking at this data, it is so applicable to my patients that I don't order gabapentin, even just based on this one study, because I didn't see a benefit. And if I was that patient, if you're going to give me a pill or not give me a pill, I'd rather not have the medication. That being said, just as Dr. Huynh said, we do have anesthesia very actively involved in managing our patients, and we welcome their input. They have expertise that we don't have. So when they order it, I'm absolutely fine with it. I look forward to this paper being published, and we can take it to our team then and see if they want to change their protocols. But again, for laparotomies, we include gabapentin in a week-long program of pain management. So gabapentin, certainly believe in it in its role in Egress protocols. Maybe we need to identify or specify where it can be best utilized.
Thank you both so much for taking the time to talk to me about this excellent paper. I look forward to it being shared and some of the feedback and comments that our community has to say about it. It's really well done.
All right. Thank you so much for having us.
Thanks for having us.
Thank you all for tuning in to MIG's Front Page this month. We look forward to seeing you guys again.